Okay, I think we can start. Hello
Okay.
everyone. Welcome to today's SPR webinar. Thank you all very much for being here today. Today's presentation is titled A Phenomenological Study of Childhood Trauma and Adult Interpersonal Relationships Among Diagnosed Individuals with Depression and Anxiety in Pakistan. Today's speaker is Natasha Shaukat. She is a licensed consultant clinical psychologist, registered with the Allied Health Professionals Council, with more than 2 decades of clinical experience in hospital, neuropsychological, community, and telehealth settings. She works with individuals experiencing neuropsychological conditions using assessment and evidence-based therapeutic approaches. She has worked extensively with underserved and trauma-affected populations through community and NGO-based initiatives. Natasha has presented her work internationally, including as a keynote speaker, and contributed to published research. We will begin the talk shortly. I will just say a couple of very important announcements before we continue. Our talk is being recorded, and we will have the recording later available on the SPR YouTube channel. On our YouTube channel, you will also find recordings of previous events and many playlists that you can go through. In addition, please make sure to keep an eye on the SPR calendar where you can see any future upcoming events. And lastly, a quick reminder that the registration to the annual SPR conference is still ongoing in Osaka, Japan, and we will be very glad to see you all there this year. Links to the YouTube channel, the SPR calendar, and to the annual conference will now be available in the chat. So thank you very much for listening to this introduction. We will start the presentation, and if you have any questions, please leave them until the end, where we will have a few minutes for discussion. And of course, if you have any questions throughout the presentation, you can leave them in the chat, and they will be addressed at the discussion portion. So Natasha, please, you can start.
Hello, good day, everyone, and welcome. Thank you so much for joining today. My name is Natasha Shaukat. I'm a clinical psychologist based in Islamabad, Pakistan, where I practice at Neuro Council. I have been working in the field of clinical and neuropsychological care for over 26 years across hospital, clinics, and online settings. Along my clinical work, I love research. And I have three published articles covering Parkinson's disease, headache disorders, and clinical case study on a rare behavioral condition, coprophagia. And I'm currently working on multiple ongoing research projects covering both psychology and neurology. And I'm honored to be a part of SPR community and grateful for them for providing me platform to discuss a very crucial aspect with you guys. My research is focused on childhood trauma and adult interpersonal relationships among diagnosed individuals with depression and anxiety in Pakistan. So comes on the first slide, from the consulting room to the research question. Before I talk about the research itself, I want to share with you how this study was actually born. This did not begin in a library or a laboratory. It began in my consulting room. Over many years of clinical practice, through careful clinical observation and through assessment of clients presenting with depression and anxiety, I began to noticing something very consistent. A pattern was too significant to ignore. When I explored the early life histories of my clients, unaddressed childhood trauma experiences kept emerging as a recurrent clinical theme across very different people from very different backgrounds. This pattern appeared to consistently that it created both a professional and ethical responsibility for me to explore it more rigorously through structured evidence-based research. I want to assure the audience that throughout this entire research process, all ethical guidelines were strictly followed. Informed consent was obtained from every participant, signed and documented. All ethical protocols were carefully maintained from the very beginning to the very end of the study. So this research is not just born from a clinical curiosity, it was built on ethical responsibility. The standard assessment and what it kept revealing. As psychologists, when a new client comes to us, we begin with a thorough psychosocial assessment. This includes exploring their early life history, their family environment, attachment figures, significant losses, experiences of neglect, and emotional invalidation. This is simply good and responsible clinical practice. So with clients presenting with depression and anxiety, I consistently observed a clear and striking connection between unresolved early life experiences and the symptoms they were carrying into adulthood. That was particularly significant was that many of these individuals had never made the connection themselves. They had never linked their childhood experiences to what they were feeling and struggling with today. So this realization combined with the consistency of what I was observing made it clear that this needed to be studied formally and responsibly. Three things these clients had in common. What really caught my attention was not just that childhood trauma was present in these clients. It was how they relate to it. Because despite coming from very different backgrounds, different ages, different life situations, different presenting problems, there were three things that kept appearing again and again. The first thing was that they had never spoken about it. Many of these clients came to therapy, and it was the very first time they had ever talked about what happened to them as a children. No friend knew, no family member knew. They had not even fully acknowledged it to themselves. It was simply buried. The second thing was they had never connected it to what they were feeling today. They were living with chronic depression and anxiety, but in their minds, their past and their present were two complete separate things. They never saw the link. Their childhood lived in one place and their pain lived in another, unconnected, unsynthesized. And the third thing, and perhaps the most significant one, it was that many of them did not even recognize what happened to them as trauma. Emotional neglect, invalidation, inconsistency, witnessing distress at home. These experiences were minimized, normalized, or simply never given a name. The phrase I heard most was that that's just how it was. Very simple. That just how it was. And that one sentence, told me everything I needed to know about why this research was so necessary. The gap between experience and understanding. In this slide is really the heart of why this research matters. There is a simple but very powerful truth here. When people carry wounds they cannot name, they cannot heal it. So think about that for a moment. It is not enough to have lived through something difficult if you cannot recognize it, if you cannot name it, if no one ever helped you to understand it. Even it stays inside you silently, shaping your thoughts, your relationships, your emotions without you ever understanding where it all coming from. Now, the research literature is really very clear on this. We have known for a long time through adverse childhood experience researches, what we call ACEs, that early adversity has a direct and lasting impact on adult mental health. This is not new information, but here is the problem. These connections remain deeply under recognized in everyday clinical and community settings. This is especially true in our Pakistani society, where mental health conversations are still finding their place, their space. And what my clinical work confirmed was something even more specific. My clients were not just struggling, they were struggling without any map to explain why. They had no framework, no language, no understanding of their pain was rooted. The connection between their childhood and their present suffering had simply never been made. So when you look at the number of the slide, years of clinical practice behind this study, three core patterns consistently observed across clients. And in many cases, no one had ever helped them explore it all again. It comes very clear that this gap between what people experience and what they understand about themselves is not just a personal struggle. It is a gap in how our society understands, talks about, and respond to human suffering. And it needed to be addressed. How a clinical pattern became a study, structured study. Good research is never born in a vacuum. And this study was not different. It grew organically from real clinical encounters, real people, real patterns. The first step was what I would call the naturalistic observation phase. Over many years of practice, I was not yet forming hypotheses or designing studies. I was simply paying attention, noticing, recording what kept coming up across very different clients with very different backgrounds. That attentive noticing was the very first seed of this research. And then came to the second step, pattern recognition and literature review. Once the clinical pattern became clear to me, I went to extending or existing research. I mapped what I was seeing in my clinic against the global literature on trauma, ACEs, attachment, and the neurobiology of early adversity. And what I found was both reassuring and eye-opening. The literature confirmed what the clinic had been showing me, and it gave me the confidence to take this further. For the third step was formulating the actual research question. And a clear, structured, stable questions studying the relationship between unresolved and unrecognized childhood experiences and the severity and maintenance of depression and anxiety in adult population. And finally, the study design and execution, the methodology was carefully selected to capture both the depth of individual experiences and the broader pattern across the population, because what we were studying was complex and deeply human. And the approach had to honor that complexity. Trauma and interpersonal relationships. Slide number 7. Sometimes something very close to the core of the research is how trauma shapes our relationships, our earliest relationships. The very first connection we have in this world do not just shape our childhood, they shape who we become as adults in every relationship we will ever have. As human being, one of our most fundamental psychological need is the need to belong, to feel loved, to feel safe, to feel seen by people close to us. This need is not just emotional, it is central to how we form our identity, how we develop emotionally, and how we maintain our mental well-being. But when this need goes unmet in childhood, when a child grows up without consistent love, safety, or emotional support, something very significant happens. They enter adulthood with a fragile sense of who they are, with a deep difficulty in trusting others, and with emotional struggle they had often cannot even find words for. The second point on this slide is something I find very important. When early caregiving is marked by inconsistency, neglect, or harm, a child begins to internalize mistrust. And that mistrust does not stay in childhood. It becomes their template, their blueprint for every relationship that follows. It shapes how they connect with others, how they protect themselves, and how they interpret the intention of the people around them. And finally, when this adversity is prolonged, when it goes on for years without recognition or support, it can result in what we call complex PTSD. This is characterized by emotional dysregulation, deep shame, negative self-perception, and significant difficulty in relationships. So what begins in childhood does not stay in childhood. It travels with us into our adult life, into our relationship, into our mental health. Theoretical foundation is very important in every research. So every good research study stands on theoretical shoulders, and this study rests on two main powerful frameworks. The first is Freud's psychodynamic theory. The second is Wahlbeit's attachment theory. Together, they help us understand both the connection of unconsciousness and the relational dimension of childhood trauma. Freud proposed something very important. He said that early childhood experiences are not simply forgotten, they are stored in the unconscious mind. So when something overwhelming happens to a child, the mind buries it. It hides it away. But here is the thing, it does not stay buried. It resurfaces later in life through emotional difficulties, through relationship struggles, through psychological distress, without the person ever making the connection back to their childhood. This is exactly what I was saying in my clinic. People carrying pain whose roots were hidden from them. Bowlby's attachment theory add another layer to this. Bowlby argued that the very first bond a child forms with their caregivers becomes a blueprint, an international working or a working model as an internal following working model for every relationship that follows. When early care is safe, consistent, and loving, it builds trust, it builds security. The child learns that the world is a safe place and the people can be relied upon. But when early care is marked by fear, neglect, or inconsistency, the child develops insecure or disorganized attachment patterns, and those patterns travel with them into how they trust people, into how they manage conflict, into how they regulate their own emotions. Trauma in the Pakistani context. At this point, I want to bring us to something that makes this research particularly unique. We are not in a Western setting. We are in Pakistan, and that matters enormously. The theories I just shared, Freud and Bowlby, are valuable. They are well established, but they were developed largely in Western individualistic societies, and Pakistan is something very different. In Pakistan, life is lived collectively. Family is not just important, it is the central to who you are, your identity, your decisions, your work. All of these are deeply tied to your family and community. There are strong hierarchies between parents and children, between elders and the young. And within these structures, there are powerful norms around family honor and loyalty. What this means in practice is that painful experiences, especially abuse or neglect within the family, are simply not spoken about. A child who suffers learns very quickly to stay silent because speaking up could mean bringing shame to the family. And that silence can last for years, sometimes a lifetime. Then there is the weight of stigma. Mental health in Pakistan remains deeply sensitive. Many people avoid seeking help out of fear of judgment, out of fear of shame. So childhood trauma goes unrecognized, untreated for years. And what happens to pain that is never addressed? It does not appear, it does not disappear. It accumulates quietly, slowly, and it surfaces later as anxiety, as depression, as relationship difficulties in adulthood, rooted not in the present, but in childhood that was never fully healed. This is the Pakistani reality that this research sought to understand and to address. And research question of current study, So this brings us to the heart of the study. And this stage, the question was no longer simply whether childhood trauma affects adult mental health. We already know about it does. The real question became, what does this look like in the cultural reality of Pakistan? What happens when a child grows up carrying emotional pain in a society where silence is often mistaken for strength, where family loyalty comes before personal suffering, where children are taught to endure quietly, and where speaking about pain can sometimes feel like breaking an unspoken rule? Because trauma does not simply disappear with time, it follows people quietly into adulthood like an invisible thread woven through relationship, emotions, and self worth. And equally important, what role does attachment play in all of this? Do early emotional bonds become the blueprint for later relationship? Can insecure attachment pattern help explain why some individuals struggle with anxiety, depression, and emotional distress, or fear of abandonment later in life? These were the questions that shaped this research, not only to understand trauma itself, but to understand how childhood experiences echo across adulthood, often quietly, often invisibly, but powerfully nonetheless. This study was guided by three central research questions. So the first question explored how childhood trauma continue to influence adult relationship, because the way we are loved as children often become the language through which we understand love as adult. Early experiences of neglect, invisibility, emotional pain, and how do adults with anxiety and early experiences of neglect, instability, emotional pain, or abuse can shape how safe a person feels with others, how easily they trust, how close they allow people to come, and whether relationship feel like comfort or emotional danger. The second question focused specifically on individual experiences, anxiety and depression. How do childhood experiences continue to shape their adult relationship? Because emotional distress really appears out of nowhere. Sometimes anxiety is not just fear of the future, it is the nervous system remembering the past. Sometimes depression is not only sadness, it is years of emotional wounds carried silently without speak to heal. And the third question looked for pattern across participant experiences. Were there common emotional struggle, relational patterns, or recurring themes appearing across different stories? Although every individual story is unique, pain often leaves similar footprints. And understanding those patterns can help us better understanding how childhood trauma continue to shape emotional and relational well-being in adulthood. Design, research design. So I've followed this research design throughout. This part of the study focuses on the research design, in the other word, how the study was actually carried out in real life. Think of it as the blueprint behind the work, the structure that guided how we moved from questions to understanding people's lived experiences. This research followed a qualitative design because uh, we were not qualitative research design, we were not trying to measure emotions in numbers or reduce experiences into statistics. We were trying to understand stories, narratives, real lives, real memories, and the emotional meaning people attach to their past. After all, human pain does not always fit neatly into graphs or percentages. It lives in narratives, silences, and personal reflections. The approach was exploratory in nature, like walking into a forest without a fixed map, not to get lost, but to truly see what exists there. Participants were selected purposefully, not randomly, but their experience were directly relevant to the focus of the study. Individuals who had experienced childhood trauma and were now navigating adulthood, including relational challenges and emotional distress. We also defined clear exclusion criteria. All those individuals who are diagnosed with any acute psychiatric instability or high suicide risk were strictly excluded for participants' ethical safety. Those individuals who had experienced any physical trauma that had potentially affected their memory or who presented any significant symptom of physical trauma were all excluded from the study. There was no exclusion of language. Data was collected through in-depth semi-structured interviews because a structured question alone are not enough when exploring something as sensitive as trauma. Semi-structured interviews allowed space for people to pause, to reflect, to go beyond surface answer and speak in their own words, all their own space. And finally, the data was analyzed thematically, meaning we look across all the narratives to identify recurring patterns, emotional threads that kept appearing again and again. Because while every story was unique, certain patterns began to echo across different lives, like familiar songs played in different voices. And it is within those patterns that deeper understanding begins to emerge. So here we will discuss the thematic analysis. This part of study explain how the data was actually analyzed step by step in a very structured way. The analysis took place in two phases. The first phase was a pilot study involving 3 participants. This small initial step was important because it allowed us to test the interview process to see whether the questions were clear, appropriate, and able to bring out meaningful responses. It was like a rehearsal before the main performance. The second phase was the main study, which included 23 participants. This is where the full data collection took place, giving us a much richer and deeper understanding of the lived experiences being explored. Once the interviews were completed, all conversations were carefully transcribed, meaning every spoken word was converted into written form. So nothing was lost from the participants' narratives. After transcription, the process of thematic analysis began. We followed Braun and Clarke method of thematic analysis. This approach is like piecing together a puzzle. We carefully read and reread the data, looked for repetitive ideas, emotions, patterns, and then organize those into meaningful themes, step by step. Raw narratives were transformed into structured insight without losing the depth and emotions behind the participant voices. In this way, the analysis helped move from individual stories to broader pattern of meaning across the data. There were three research questions. First, the findings related to the first research question provided a broader lens for understanding the vital role of childhood trauma in affecting the interpersonal relationship of the participants in their adulthood. It is evident through quotes and sub-themes that participants were constantly linking their adverse childhood experiences with the problem they face in their adulthood. And their adulthood difficulties in trust, emotional closeness, lack of self-worth, and lack of relational security. The major themes that were described under this theory were trauma exposure and early adversity, attachment anxiety, and maladaptive coping, illustrating the profound psychological and relational outcomes of childhood trauma in adulthood. We see through empirical evidence that if relational needs are not met when needed, they disturb a person's hope and vitality, and negative beliefs like guilt and shame are reinforced, thereby disturbing their psychological state. Being anxious about attachment or closeness emerged as the second most prominent consequence of trauma in early life on the relationship of adult. In the present study, attachment insecurity was characterized by fear of rejection, mistrust, fear of intimacy. Early traumatic experiences affect cognitive processing and emotional development, which leads the person to several maladaptive consequences. Maladaptive interpersonal patterns often serve as coping strategies in which social withdrawal, conflict with family, and maintaining distance from others are common practices that disrupt their social connection and relationship. To avoid emotional triggering scenarios in their life, conflict in their relationships, or any closed emotional involvement, participant reported using avoidance-based coping strategies. Research question 2. This question focuses on individual experiencing anxiety and depression. It explores how their childhood experiences continue to influence their current relationship, especially in terms of emotional regulation, attachment pattern, and relational struggles. So here the focus is on understanding how internal emotional difficulties and early relational wounds interact in adulthood. A total of 4 themes: emotional dysregulation, anxiety-related manifestation, depressive experiences, and maladaptive coping were identified, which best explain the lived experiences of individuals who have diagnosed with anxiety and or depression and suffering through childhood trauma. Emotional abuse and neglect during early years of life have been associated with different dimensions of emotional dysregulation, as people diagnosed with depression and anxiety often experience emotional decontrol, inattention, and rejection sensitivity, which in turn suggests that different adverse experiences often shape emotional regulation capacities differently in adulthood. Emotional dysregulation is not just an evident symptom of anxiety or depression, but rather it often functions as an integral mechanism through which early childhood trauma voiced long-term effects on emotional functioning. Moreover, people who 73 experiences and anxiety, depression, frequently experience recurring fear of different things like rejection, loss, or criticism. Excessive vigilance, fear of the unseen, and somatic symptoms of anxiety, all of which are associated with early childhood trauma. Research question 3. This question looked across all participants to identify patterns. Instead of focusing on one individual story, it asks, are there common themes or repetitive emotional experiences across different people in narratives? This helped move from individual experiences toward broader psychological and relational patterns. There exists a consistent and sequential pattern of personal experiences among individuals who are victim of childhood trauma. Instead of this being an isolated phenomenon, uh, there exists an interconnected trajectory of events that explain patterns in which a problem begin with early adversity and extended to it into adulthood, affecting their emotional, psychological, and attachment patterns. Empirical evidence suggests a childhood atmosphere marked with neglect, conflict, and emotional threats may alter emotion processing, and longitudinal and cross-sectional research suggests long-term problem in emotional stability and elevated stress level to stressors in adulthood. This then leads to heightened anxiety and emotional problems as trauma sensitizes the threat system. So the victim lives in a constant state of fear, which was reported by the participants of the study as well, that they face a constant fear of rejection, isolation, mistrust, and judgment from others, which eventually stops them for interacting and healthily dealing with others. Interestingly enough, these patterns of personal experiences also come with an emergence of adaptive coping behavior, which includes therapeutic engagement, journaling, cognitive restructuring, faith in God, and social support utilization. Several participants suggested therapy as an instrument tool for coping with maladaptive behavior and overcoming their faulty thoughts. As the sample is comprised of Pakistani population for which spirituality and faith has a significant role in their lives. Participants also reported seeking help through prayers and building a health relation with God. Past, present, living separately. One of the most striking findings in this research was something that I had sensed in my clinic for years. But seeing it confirmed through structured research made it even more powerful. The past and the present were living in completely separate worlds inside these individual sealed off from each other with no connection between them. One side what they carried from childhood, experiences of emotional unavailability, inconsistency, neglect, early loss. These were the experiences that shaped how they learned to feel about themselves, what they learned to expect from others, and how much space they believed they were allowed to take up in this world. And here is something very important. Many of these were not traumatic events. There were no a single big moment. They were quite accumulated. The everyday texture of a childhood, the simply did not feel quite safe. On the other side, what they were living with now, depression that felt sourceless, anxiety with no obvious trigger, a persistent sense that something was fundamentally wrong with the world or with themselves. And the most significant thing, these were not people who lacked insight. They were intelligent, aware, thoughtful people. They simply had no bridge, no connection. No one had ever helped them well one. What this meaning for how we assess as we come towards the end of this presentation, I want to talk about what this research actually mean for us as clinicians in our everyday practice. Because this research does not ask us to change everything, it asks us to do something much simpler, to ask one more question and to take the answer seriously. The first thing in the study tells us is that early life history is not background information. It is not something we collect at the beginning and then set aside. It belongs at the very center of how we understand our client, not as a ticking exercises, not as a routine form to fill in, but as genuine invitation to explore. Because when we treat early history as secondary, we may be missing the most clinically significant material in the room. The second thing is something very every clinician needs to clear. Many clients will not name what happened to them as trauma. They will say it was just how it was, or it was nothing serious. And part of our clinical skill is hearing the weight underneath those words without leading the client, without projecting our own, without projecting our own interpretation, and without rushing to reframe their experience before they are ready to hear it. This is very important. And the third point is perhaps the most quietly powerful finding of this entire study, simply being asked about their early life, carefully, respectfully, without judgment, caused something to shift in many participants. For some of them, being truly heard and witnesses that telling was an experience they had never had before, not once in their lives. That tell us something very important. The act of naming has therapeutic value in itself. Before any intervention, before any technique, just asking the right question with care and without judgment can begin the healing. This final slide begins with some different results and different purposes of this current research. It brings us to what I would call the therapeutic direction of this work, not just what the findings show, but what they quickly ask us as clinicians to carry differently when we sit with another human being. Because research at its best does not end in conclusion, it ends in responsibility. And in this case, that responsibility feels very human, almost like a quiet question sitting in the therapy room when someone finally trusts you with their story. How do you hold it without breaking it further? The first pathway is creating space for the story. And this is not a technique, it is a stance. It is the way we sit, the way we listen, the way we don't rush to fill silence. It is allowing a person to enter the room without having to be together, without performing strength, without polishing their pain into something easier to hear. Because many of these stories have never had air before. They have been kept inside for years, sometimes wrapped in shame, sometimes in duty, sometimes in survival. So when they finally come out, they don't come out neatly. They come out in pieces, in pauses, in long silences that say more than words ever could. And in those moments, therapy becomes very simple and very scared. You are allowed to exist here exactly as you are. The second path is psychoeducation, but held gently, not as explanation that sits about the person's experience, but as something that walks alongside. Sometimes people need language for what has lived inside them for years without one. And when we connect the dots, early attachment, emotional neglect, instability, to what they feel now in anxiety, depression, or relationship, something soft often happens. Not always inside in a dramatic way, sometimes just a quiet relief. Oh, like, oh, I'm not broken, I'm shaped. This is positive response. And that shift, the moment of meaning, can be deeply regulating in itself because chaos becomes a little less frightening when it is understood. The third pathway is space and tighter exploration. And this is where the therapist's heart really has to stay present. Because trauma works is not about going deep quickly. It is about respecting what the nervous system can actually hold in that moment. Sometimes the most therapeutic thing is not going further. It is noticing this slight change in breath, the tightening in the voice, the shift in gaze, and saying we don't have to go there right now. It is working like a careful gardener, not pulling all the roots, but gently checking the soil season by season, moving closer when there is capacity, stepping back when there is overwhelm, always in dialogue with safety. And finally, revising the formulation together. This is where something deeply relational happens because we stop being the expert who explained the person and instead become someone who is trying to understand with them. We build meaning together. We adjust it together. We sometimes even unlearn what we thought we understood. And in the process, something shift in the relationship itself. The person is no longer just a case or a story to be analyzed. They become a collaborator in their own meaning making. So in the end, these pathways are not just interventions. They are ways of being with another human being who has learned often too early in life what it means to carry pain alone. And maybe the deepest takeaway is this: a healing does not begin with interpretation, it begins with presence, with patience, and with the quiet courage to stay with someone's story long enough for it to finally feel safe to be told. Thank you for listening me. Much patience. Floor is open for any question.
Natasha, thank you so much for such an incredibly important presentation. We have time for a couple of questions. Denise, do you want to ask?
Yes. I have comments to make, but I will. I don't know how much time we have, Galit. But I will favor questions. First of all, thank you, Galit, for organizing it, and Natasha for sharing this. I'm very worried that very few people came, and this is a diagnosis, no, of how this issue is looked. People look ahead, beside. I mean, look, don't reject it or don't want to know. So that's a question. But I have two questions, two precise questions. One is
Yes.
concerning disclosure, because I am not an expert in the field, but I have heard from experts that the moment these dissociated memories emerge is a moment of high risk of suicide and even of very aggressive externalizing reactions. And the second question is this: I know that in India, early marriage is produces the main cause of suicide in women, in girls of 12 when they are forced to marry. But I don't know what the situation is in Pakistan. And if we have time, I make comments, but Galit will tell me.
So India and Pakistan both are brother and sister countries. Social values and overall customs and persons' interaction are almost same. And yeah, it's true. When a person doesn't heal correctly or finally memories bring it with pain and internal emotional dysregulation. So if you will ask about the research question during the research, how I tackle these conditions. So there was a proper arrangement to provide therapy to every participant at the spot.
Denise, would you like to ask anything else?
Yes,
Yes, please go
I'd like to make a few comments. Thank you. First is on how this has been horribly misunderstood and neglected in the psychological field. When Peter Fonagy took over the Anna Freud Center, his first task was to call all the people who were now 30 or more or older to ask them how did it work with child psychoanalysis in the first cases. Majority was very useful, but there was a minority for which it had been absolutely destructive, and they were exactly the abused and maltreated children, because the therapist interpreted this not only as a fantasy but as a wish. So they felt absolutely neglected and I would say re-victimized. The second comment is has to do with the important the issue on complex depression which is resistant to therapy or psychotropic medication, and 65% of this stems from early trauma. And the third comment is the fact that early trauma inhibits the development of the hippocampus, which is the area of the brain devoted to memories. Which is very important in its implication for our technique, which is often used in emphasizes exploration. There's nothing to explore. It's not there. It's somewhere else, but not there. Not in words, not in clear memories. And it also, this early trauma exaggerates the development of the amygdala, which is the organ of alert and aggression. And this is very important. I work a lot with people having violent behavior. And it's very important to understand violent behavior, because this early trauma shows the child that the world is dangerous and the best he could do is to defend himself. So any attitude is immediately understood as aggression and reacted upon. Thank you.
Thank you for such insightful comment. It's always important to share and explore ideas together when we are in the same community. This is the best way to learn with each other's experiences, informations, and sharing. Thank you.
Thank you, Denise, for your comments. Thank you, Natasha, so much again for a very, very meaningful and very important talk. I just want to give a quick reminder that the recording will be available on the SPR YouTube channel. And also we have the SPR calendar with all of the upcoming events, and a last reminder to register to the upcoming conference as well. And also, I myself still have a few comments and questions. So if anyone wants to maybe reach out to you, Natasha, would you like to leave your contact information in the chat or your email in the chat?
Please, I would like to share here.
Why don't you share now your concerns, Galit?
I would like to reply thoroughly, deeply, in a very explanatory way. I really would like.
I will, Denise, I can share my comments. Maybe I'll just share them, and Natasha, you can reply to them by email if you would like. I just had a few small thoughts that I had while listening. You mentioned that a lot of people don't recognize their trauma as trauma until a very late stage. And I was, thank you, Natasha, for sharing your email. And I was wondering about how as you've mentioned, a lot of the times people don't recognize their trauma as trauma because they're raised in an environment where the events that they are experiencing aren't considered trauma. And when they are later as adults do realize that this would be a traumatic event, this is something that could be identified as trauma, how hard it is when your environment still doesn't recognize it as trauma. So it's recognized in the therapy room, it's recognized with yourself, but it's very hard when you go out back to your family and your environment and your friends or whatever environment you're in, and it's still not, maybe not as recognized, then you still have to deal with it not being addressed as a traumatic event. And also, I was wondering, you've mentioned that a lot of times these children grow up to be mistrusting adults, and I was wondering how the experience of interviewing them was. It must have been very difficult. It must have taken some time to establish some kind of an alliance to allow them to feel comfortable to discuss such sensitive topics. So those were the two main comments or main thoughts that I had. So Natasha, feel free to address maybe shortly, and then by email, I would be very happy to hear your thoughts.
So your observation is really very clear and deep. People really don't recognize that they had suffered with different traumatic events in their early childhood, because especially in our Pakistani society, trauma, we don't feel good to share pains and unpleasant or traumatic events like physical, sexual, emotional abuse and neglect, because in Pakistani culture, sharing these thoughts or sharing these incident with others, it looked like that these things are shameful. People will make fun of them, or people feel bad for them. So parents or the elder person of the family, they always ignore or always suppress these kind of things. So a child has no idea with whom he can share and how he can explain his feelings. He grew with these feelings and emotions and thoughts by suppressing. And when he grew up as an adult, he developed insecurity and developing trust and building healthy, positive interpersonal relationships in romantic relationships with family members, siblings, parents, even at workplace. They have feelings of insecurity and fear of rejection. So when things remain unspoken, they cannot heal. The first step in our country is to take step. I wish I can play some positive role to develop community centers and community centers in national level to support system for parents and children on the spot. First, we need to develop some positive and healthy approach related to psychotherapy, counseling, and therapeutic intervention. In Pakistan, mental health or going to or seeing to a therapist is still a stigma. People feel shame if they are going for therapy or if they are seeking some kind of professional help. They feel bad, they feel shame. If they seek help, they hide it from others. They mostly prefer to go to the psychiatrist. They prefer to take medication to suppress their emotions and feelings rather than to resolve their thoughts or emotional dysregulation through therapy or any intervention.
Thank you, Natasha. Thank you so much for your informative and again very meaningful response. If we don't have any more questions, I think we will close the talk for today. And again, Natasha shared her email, so we can reach out to her and ask more questions. Natasha, thank you so much.
Thank you. Thank you.
Thank you, everyone. Thank you, everyone, for attending. Thank you to the listeners on the YouTube channel, if you're watching. And thank you, Natasha, of course. Thank you so much.
Bye.
Bye.